Good evening, everyone, and thanks so much for joining us. Tonight, we are going to be discussing what I suspect is on everybody's mind in our country and around the world, and that is the coronavirus pandemic, which is impacting our country so significantly in countries all over the world. And we have a wonderful panel tonight to join us. We're going to start in a few minutes with Congresswoman Pramila Jayapal. And as many of you know, Congresswoman Jayapal is from the state of Washington, and that is one of the epicenters of the pandemic. And we're going to talk to the Congresswoman about what's going on in Washington, where they are at right now, where they hope to go, what other states can learn from the tragedy that is impacting the state of Washington right now. Then we're going to go to one of my favorite musicians for a short break, because technologically we need some break here to go to our next guest, and that's Sara Lee Guthrie. And some of you may know she is the daughter of Arlo Guthrie and the granddaughter of one of the great folk singers and writers in modern American history, and that is Woody Guthrie. And she'll be singing for about 5 minutes, and we thank her very much. Then we're going to go to Dr. Abdul El Sayed, who is a physician, epidemiologist, public health expert, former health commissioner for the city of Detroit. And I think we're going to ask Dr. El Sayed to play family doctor tonight to kind of answer the questions that are on people's minds about how the disease is spread, what happens if you get it, where do you go. And by the way, at the end of the program, we'll be welcoming your questions. You can ask me questions, but probably you'd want to ask the doctors. They know a little bit more about it than I do. After we hear from Dr. El Sayed, we'll hear from Dr. Recede Desai, who is a former Epidemic Intelligence Service officer in the Division of Viral Diseases at the CDC, a former pediatric infectious disease fellow at the University of Southern California, and is currently the chief medical officer of Osmosis, a healthcare education platform. And then we'll go to Dr. Joya Mukherjee, who is an associate professor of global health and social medicine at Harvard Medical School, associate professor of medicine at Brigham and Women's Hospital. And although she's joining us tonight in her personal capacity, since 2000, she has served as the chief medical officer of Partners in Health. Now, before we get to our guests, what I want to do, which I think is on people's minds as well, is briefly go over the package that the Senate is working on as we speak. I expect that I'm not going to have to run out for a vote, but if you see me depart, that's where I'll be going. But they are putting the finishing touches on the largest financial package of new money in the history of the United States. I expect the package will be over $2 trillion, and that excludes many trillions of dollars coming from the Fed. And the idea of going big is something that not everybody agreed with at the beginning of this discussion, something that I thought was absolutely imperative. And I'm glad we are coming up with some serious money to address an unprecedented crisis. Let me just very briefly go over some of the details. And the best I can tell you is this is the latest information that we have. Things change all of the time. Literally, negotiations are going on as I speak. We're talking about $250 billion to be provided to expand unemployment insurance. This is a concept that I fought for. My belief is that in this crisis, we've got to make all American workers whole. This bailout should not be just for large corporations. It should be for working families, for lower income people, and for the most vulnerable people in our country. This unemployment provision will essentially allow furloughed Americans, those who have been laid off, to receive 100% of their prior income, capped at $75,000 a year for up to 4 months. Importantly, at a time when fewer than half of Americans are eligible for unemployment, To the best of my knowledge, this covers gig workers. You're driving an Uber car, you're covered. You're a waitress, you're covered. This covers, to the best of my knowledge, now there may be things that I don't know here, to the best of my knowledge, virtually all American workers. Furthermore, some of this money will go to work sharing programs that will subsidize the wages of employers who don't lay off workers. So if an employer keeps that individual working, they will get a full payment for the salary of that worker. This proposal will provide $250 billion in a one-time check of $1,200 for adults and $500 per child. I wanted much more, frankly. I thought we needed $2,000 a month. Republicans essentially wanted a lot less. That is where they are right now. And these checks will be made out to individuals making less than $75,000 a year and households making less than $150,000. There will be $350 billion to go out in forgivable loans to small businesses who do not lay off workers. It's an idea that kind of some of us have been pushing, and that is if you're an employer, in this case a small business person, you don't lay off your employers, you'll get a forgivable loan. It starts off as a loan, you hang on to your employees, that loan will be forgiven. At a time when states are losing revenue, tax revenue big time, cities as well, there'll be $150 billion that go to states and cities and counties. There will be $130 billion provided to reimburse hospitals for lost revenue related to the coronavirus. Hospitals now all across this country are stretched out. They are losing revenue. They're going to have to expand their capabilities to take care of an influx of people who have the virus. This will be a shot in the arm for hospitals all across this country. Now, what is the most problematic aspect of the bill to me is that $500 billion are delegated at this point. I don't have all of the details now. They're still being worked on to be distributed to businesses at the discretion of the Treasury Department. And the concern here is $500 billion is a huge amount of money. The Republicans originally wanted kind of a blank check to get that money out to anybody they wanted in any way they wanted with virtually no transparency. People would not know who got the money, what the terms are for a very, very long time. And the fight right now is to say, you know what? If you're going to provide money to these large corporations, we want to know how that money is being spent. We don't want cash. We don't want stock buybacks. We don't want you to be raising the salaries of your CEOs. We want the money to go to workers. We want the money to be used in a productive way. And the American people have got to know right away with transparency and oversight how that money is being spent. There is also a provision in there, again, I have problems with this, for free testing for the coronavirus. You can get tested for free, but not free treatment. My own view, which did not prevail in this discussion, is that in this emergency moment, every American should be covered by the federal government for health care. And that means Medicare for those people who have nothing or underinsured, and to supplement the private insurance of people who have large deductibles and copayments. But that did not prevail, and I worry about this provision very much. Our community health centers will receive $1.3 billion in emergency COVID-19 funding, which will help some of our primary healthcare providers. And there are a number of other issues out there, some that have not yet been dealt with, as I understand it, is a moratorium on foreclosures and evictions. People should not be losing their homes, should not be thrown out of their apartments. I'm worried about what happens to the most vulnerable people in this country, the homeless, people in prisons. I'm not quite sure that that has been effectively addressed. It is absurd that we remain the only major country on earth not to provide paid family and medical leave. That has not yet been addressed so far. A suspension or moratorium on student loan payments, not addressed so far. Adequate nutrition assistance. You know, you're gonna have a lot of people out there without the income they need to buy the food they need. That is pretty crazy. We gotta make sure that the SNAP program is significantly increased, not yet dealt with, and some other provisions as well. So that is a very brief outline of what is in a bill which is not yet completed, which is still, as we speak, being worked on. What I want to do now is go to Congresswoman Pramila Jayapal from the state of Washington. Sadly, the state of Washington is one of the epicenters of the epidemic. And what I would like Pramila to discuss, if she could, is talk about how the state has responded to the crisis. Was that response adequate? What is the situation now? Does the state of Washington have the beds, have the ICU units, the ventilators that they need? Do the doctors have the gloves, the gowns, the masks that they need? Where do you think Washington is going to be in a few months? You're right now in the middle of the crisis. What do you see happening in a few months? And maybe, Pramila, what can the rest of the country learn from the state of Washington's experience? Pramila, thanks so much for being with us.
Thank you so much, Senator Sanders, for inviting me to join you on this national live stream, and also just for your continued bold leadership to address all of the challenges that we're facing today. As you said, I represent Washington State's 7th District, and that includes most of Seattle. And I'm also very proud to serve as your National Health Policy Chair for your campaign and the lead sponsor of the House Medicare for All bill. These have been incredibly difficult days for the entire country. And, you know, across the country, what we're seeing is over 44,000 cases and 544 deaths. In Washington State, we were hit early. First case diagnosed was here in Washington, just right outside of my district. And as of yesterday, we had 2,200 cases and 110 deaths. So that's 28% of all the fatalities in the country. Our state and local officials have acted very smartly, very boldly, very proactively, and frankly, we're fortunate that we have a public health system in Washington State that is, in my view, one of the finest in the country, and it's because our Democratic governor and state and local electeds have continuously invested in that public health system and consistently linked to science and research, even as the federal government disinvested consistently across the country. And so that allowed us to be ahead of the curve a little bit, to be processing the most tests per capita in the country by getting a testing lab, the UW Virology Lab, up and running at the University of Washington, that by the end of this week will be processing about 5,000 tests per day, along with the state health labs.
Excuse me, let me say that again. You're going to be doing 5,000 tests per day?
Per day.
Wow.
And that sounds like a lot compared to the rest of the country, and it is, but I will tell you it's still inadequate for what we need. The other piece that I would say, Senator Sanders, is that our history in this city and in this state of leading with progressive policies and ideas has meant that our response is far better. So as you know, we were the first major city in the country to pass $15 minimum wage. We have some of the most inclusive immigration policies. And what that meant is that our movement was able to quickly move ideas like statewide and local moratoriums on evictions, which you mentioned we're trying to get at the federal level as well, rental assistance subsidies, and addressing COVID-19 issues within our criminal justice system. We've put in place many of those protections at the city or in some cases at the state level. But the challenge is twofold. First, that we are still very far behind where we need to be. And part of that is a far too uncoordinated federal response to getting critical protective equipment, PPE we call it, and ventilator supplies to us. You mentioned hospital beds. We have dramatically low hospital bed capacity, as well as isolation and quarantine facilities to deal with the crisis. So what we are now doing, because some of our hospitals are at 80, 90, even 100% of capacity, we will be getting some federal assistance from DOD to set up some temporary hospital facility or medical facilities. What we will do is move some of the people that just don't need the hospital equipment into those kinds of DOD tents, health tents, so that we can preserve our hospital beds and our ICU beds for those who need them the most.
Medical personnel have the masks and the gloves and the gowns they need?
They do not. They do not. Just today, I was able to get another 4,000 masks from our port, which had, the Port of Seattle had some extra masks. We're literally going around begging for masks because this goes to an important thing. The government needs to utilize the Defense Production Act and actually use it to demand and support domestic manufacture and purchase of massive amounts of what we need. I mean, we need millions of these things. And we're still letting the private sector drive the marketplace. We're not expanding supply sufficiently, and our states are bidding against each other on critical items like ventilators or masks. We also can't keep our health workers safe, which is crucial, but there's other first responders also, and I include in that, by the way, grocery store workers, bus drivers, others who have to continue to keep our systems going. The other challenge, Senator, is the scale of the crisis and the losses that are going to accrue to an already deeply unfair, unjust, and inequitable system that has already, for decades, actually penalized Black and brown workers, low-wage workers, poor people, and the most vulnerable. So we need immediate support to people right now, but we also have to fix the overall systems that made us so unprepared and vulnerable in the first place. And there's a real tension that you are seeing in the Senate bill that we will see in the bill that we have to vote on between using existing systems to quickly deliver as much as possible in terms of direct cash support and benefits, expanded unemployment insurance, all of those things, which is incredibly important. But those systems still leave out a whole host of people, even if we expand them to the maximum. And so the recognition that our systems are far too patchwork and there's a whole set of missing federal policies that are big enough and bold enough, the things you've been advocating for on the campaign, things like universal health care, missing systems that provide mandated paid family and medical leave, universal child care, some sort of a payroll guarantee system to keep workers on payroll instead of going to unemployment in the first place, comprehensive and humane immigration reform so that we wouldn't have to worry that immigrants are left out of anything, and of course, broad and strong collective bargaining provisions that allow frontline health workers like those healthcare workers who are right now sort of at the mercy of hospitals who decide whether or not they're going to get their masks, whether or not they have to reuse their masks, all of those things. We need those collective bargaining provisions that would allow for strong worker policies. And so, you know, if we had Medicare for all in place, we would have been far better prepared to handle the crisis. It's centralized, which means we can respond quickly. It's universal, which is necessary in a public health crisis as well as all the time. You can quickly contain the costs with negotiated prices of drugs and vaccines and equipment that's needed. And of course, combined with free higher education, something else that you've been advocating for, countries that have both of those things can have a broader and deeper public health pool to draw from.
Okay, Pramila, let me interrupt you and just ask you to please hang on there. I want to get to some of the other the medical people, and then we're going to bring it back for a general discussion. Can you hang in there with us for a while?
Sure, I will.
Okay, thanks very much for that report from one of the epicenters of this crisis. And now we are going to go to our singer, who is Sara Lee Guthrie. And Sara, take it away.
Watching my Bernie 2020 musical session. Enjoy. As I went walking that ribbon of highway, I saw above me that endless skyway. I saw below me a golden valley. This land was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. Oh, I've roamed and rambled, and I've followed my footsteps through the sparkling sands of your diamond deserts, and all around me a voice was sounding. This land was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. Oh, the sun comes shining as I was strolling, the wheat fields waving and the dust clouds rolling. As the fog was lifting, a voice was chanting. This land was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. There was a great high wall there that tried to stop me, and on the wall it said no trespassing. But on the other side it didn't say nothing. That side was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. In the shadow of the steeple, I saw my people. In the relief office, I saw my people. And as they stood there hungry, I stood there asking, was this land made for you and me? This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. Nobody living could ever stop me as I go walking my freedom highway. Nobody living can make me turn back, 'cause this land was made for you and me. This land is your land. This land is my land. From California to the New York Island, from the Redwood Forest to the Gulf Stream waters. This land was made for you and me. This land was made for you and me. Oh, this land was made for you and me.
Okay, let me thank Sara Lee Guthrie for the music. Let me remind the viewers that if you have any questions for the doctors, for me, please send them right in. Now let me introduce Dr. Abdul El Sayed, who is a physician, epidemiologist, a public health expert, and he's the former health commissioner for the city of Detroit. And Dr. Sayed, what I'd like you to do tonight, if you could, is we have many hundreds of thousands of people viewing this program. Why don't you kind of act as the family physician for them in terms of explaining how the disease is transmitted, what we can do as individuals to stay safe. So why don't we start with that one?
Absolutely. Thanks, Senator. So what we're talking about here is a virus. And, we talk about the name coronavirus, but that's actually a misnomer. Coronavirus is just a class of viruses. Other coronaviruses were SARS and MERS. This is just one particular one. What it causes is a pretty prescribed set of ailments, including a fever and a dry cough, a viral pneumonia. And this viral pneumonia is the part that's deadly. It's substantially more deadly and a lot more dangerous. The older you get, certainly after the age of 65, the risk goes up exponentially for a bad outcome with it. And for folks with underlying chronic diseases, particularly lung disease, it can be really dangerous. What we are all doing right now is protecting ourselves through physical distancing or social distancing. And the goal here is to protect our health system from an onrush of cases that could overwhelm the healthcare system. How does it get transmitted? Well, either people being in proximity with each other, breathing the same air, little micro droplets that come out of your nose and mouth, or it can be shed and then go onto surfaces. And new research suggests that it can actually last on those surfaces for some time.
Let me ask you this, if I could. Now, I'm going to play the dumb bunny here. I struggled with biology in college, so it's going to manifest itself now. But I can understand that somebody who has the virus sneezes in the face of somebody else, you cough in somebody's face, the virus is transmitted. How is it transmitted if I'm simply in a room? Somebody has the virus but is not coughing, is not sneezing. How could it be transmitted in that situation?
Yeah, the most common thing is, we don't really register this, but we touch our faces all the time. And from the limited amount of information that we actually do have with this virus, I mean, it's a pretty young virus. It's only been in humanity for 5 months now. Is that it actually sheds in a pretty what we call high titer, but a lot of viruses can come out. And we touch our nose and our face all the time. I mean, if you're just watching these screens, you'll see us doing it.
Right.
And when you touch it, right, then you go touch somebody else's hand and they touch their face. You may be touching something. I mean, these phones that we have all have on us can be a real nidus because we're constantly touching them and touching other things. And so that's usually how it happens. The sneeze scenario is the one that everybody sort of knows. You got somebody who's like coughing quite a bit. In fact, in this particular case, it's not really a sneeze, it's the cough. And to stay away from them. But also, what we're starting to understand is that there's probably a high probability that this disease can go asymptomatic in certain people. And in those asymptomatic people, they may be, in fact, spreading it even though they don't have symptoms. And so this is the really concerning situation because people know that if I'm sick, right, I stay away from other people. It's a kind and conscientious thing to do. But if you don't even know you're sick, then you may not be doing those things. And so you may be out and about in the world. And that's why it's so important that we socially distance because we may not know if, in fact, we are carrying the disease and maybe passing it on to other people. And so it's really critical that we stay home. And that is the key advice that we're hearing everywhere. We've seen about 100 million Americans are now under stay-at-home orders for that reason. And, the key point, Senator, that I think has to be made again, and we're hearing it everywhere, but I want to say it just one more time, is that in young folks, they may think, well, my risk of a bad outcome isn't all that high. So, if I go out, I might get it. It'll be okay. I'll feel sick and I'll be fine. The problem, though, is that you may become a nidus. You may become the transporter of that virus into somebody else who can make them all sick and make them very sick.
And may not even know it. Is that correct?
That's exactly right. And so we've got to pretend like we have the disease and we don't want to pass it on to people we love who could have a really bad outcome. And then on top of all of that, the key point about flattening the curve, and I have to say it one more time, is the key point about flattening the curve is that we only have certain levels of healthcare resources. We were talking to Congresswoman Jayapal, who was talking about the limited amount of personal protective equipment on the front lines for healthcare workers. And if we spread the disease fast enough, if we can't delay the spread, if we can't reduce the number of people who get the disease, then it may overwhelm our healthcare system. And we're seeing really scary things out of Italy and Spain, where doctors are literally having to make decisions about who lives and who dies because there's only one respirator and 2 or 3 patients who need it. We don't want to get there. And so it's really important for us to make sure that we are not a part of spreading the disease. And this disease is actually quite contagious. On average, 2.5 people will get the disease from every one person who gets it. And if you think about all of those 2.5 people, spreading it to 2.5 more people, over time, you're talking about thousands and thousands of people. And so even if it may not be a serious case in us, we've got a responsibility to protect the rest of us. And it's really, quintessential to your message is that we're in this boat together. What we do together, what we do individually influences the lives and the livelihoods of other people. And we've got a real responsibility to protect all of us.
All right, doctor, go through the symptoms again. How does somebody know that they may have the virus?
So, we always look at exposure. Did you come in contact with somebody who had it or, was presumed to have it? But the symptoms themselves are a fever, right? And a dry cough. So, when you think about a productive cough, you cough and stuff comes out, that's a productive cough. It's not that cough. It's a dry cough. And then in serious cases, folks complain of shortness of breath. They can't pull in a full breath. And that's when it gets really serious. In fact, for most people, if you have these symptoms and they're not serious and you don't feel like, it's really taking your breath away, then the best thing to do is isolate and stay home. But in those folks who feel like they're really short of breath, I can't take a full breath and I'm worried about my ability to actually take oxygen in those folks, that can be really serious. And folks need to come to clinical care in those circumstances.
Doctor, if somebody develops the symptoms, not the most serious symptoms, is there any treatment or do you just stay home and rest?
If it's not serious symptoms, then stay home and rest, right? And the same things we always tell everybody when they've got a viral illness, make sure that your symptoms don't get more serious. And if they do, then you need to go get care. But make sure that you're drinking fluids, make sure that you're certainly socially isolating from folks so you're not passing it on. Make sure that you are taking care of yourself and getting the rest that you need. But usually those symptoms subside. But in the cases that they get serious, and certainly in older folks who think that they may be exposed and may be having symptoms, they've got to call their doctor and be in communication with their doctor because they may need serious care. And for folks who do get a serious case, the most important thing we can do right now, there aren't clinically proven treatments for this. The most important thing we can do is keep them ventilated. And for some cases, in very serious cases, they may have to go on a mechanical ventilator to keep them breathing and keep them oxygenated while their body develops the immune response to be able to take on this virus and kill it away.
What is your best guess as to when a treatment might surface or a vaccine might be developed?
So the first candidate vaccine went into phase 1 trials. And let me just walk folks through how this works. You've got 3 phases in a vaccine trial. The first is we just want to make sure that this thing doesn't hurt you and that it's creating the immune response that we expect in your biology. And that part of the trial, it's the longest part of the trial of the full phases. It's the longest phase, it's 14 months. After that, phase 2 and phase 3, and phase 3 is where we actually test whether or not it's efficacious and it protects people from the disease. That can be done in about 4 months. So from 2 weeks ago, we're at best case scenario, we're talking about 18 months to have a vaccine, right? And then you have to manufacture the vaccine. And when we're talking about something as serious as coronavirus that's affecting as many people, you're talking about creating or manufacturing that amount of vaccine at scale, which is not easy to do. And so vaccine is not, it's not right around the corner. There are some treatments that have been proposed. There's one that a certain politician keeps trumpeting, but they haven't been tried in rigorous trials. So, what makes modern medicine modern is that we use evidence. We ask, does this consistently change in outcome for a group of people if and when we've randomized people to getting this particular drug? And unless we can show rigorously in different trials, in different groups of people, that in fact having this particular medication reduces the symptomatology or the length of disease, then we don't consider it evidence-based, and we don't enter it into the pantheon of treatments that we use. Now, it may be the case that you use things on the front lines because patients are really sick and you're trying everything, but to say that there are treatments out there for coronavirus specifically would be irresponsible based on the reading of the science.
And you know that named politician would never do such a thing, right? We know that. We know that. All right, Dr. Said, thank you so much. If you could stick around for some questions and discussion, appreciate it. Our next panelist is Dr. Recede Desai, who is a former Epidemic Intelligence Service Officer in the Division of Viral Diseases at the CDC. Dr. Desai, thank you so much for being with us.
Thank you. Yeah, I really appreciate the opportunity to speak about COVID-19. Thank you for having me, Senator Sanders.
What is your sense of how our country and the world are doing in terms of treating this epidemic, this pandemic? It sounds to me like we have not been particularly well prepared for it. Or am I missing something?
No, I think that's a fair assessment. So we learned about COVID-19 from the WHO at the end of last year. That's why it's called COVID-19 2019. So it's been around and has been known about since then. Since learning about it, different countries have reacted differently. And we see that the policies that they put in place have affected their outcomes. So let's look at countries like China, South Korea, Singapore. These countries have taken certain measures. They've been very quick to jump on this disease. They've started, flattening the curve. You heard that phrase just now. And what that means, in short, is they've said, let's create travel restrictions. Let's create work restrictions. Let's isolate and shut down non-essential businesses. Let's take this really seriously because, again, you want to make sure that epidemic curve, which is to say the number of people that get sick per day, is as low as possible. And then the other thing is, and the other half of this, and I want to introduce a phrase to you to help kind of summarize how I think about it, is to raise the line. And that line is on that same graph. You've got kind of the healthcare capacity line. You want to raise that as high as possible. So you want to raise the line, you want to flatten the curve, and together you can kind of help handle this situation. These first countries did that. And if you look at it now, China is essentially now coming out at the other end of the tunnel. They're doing a great job of saying, hey, we've got fewer and fewer cases domestically. Let's make sure we don't re-import cases from the rest of the world. Right now, the US today has more cases of COVID-19, new cases today, than any other country in the world. That's just today. By this weekend, we'll have more cases than any other country cumulatively, including China. So by this weekend, we'll have achieved that very, very sad benchmark. And so the reason is we're not in that first group of countries that took this very seriously. We knew about it when the rest of the world did, but instead of acting in that same sort of aggressive way, we instead did something different. We initially said, well, it's not a big deal.
Well, it's not we. Let me interrupt you, Doctor. I mean, I don't intend to become very political tonight, but it's not the we. We had a president of the United States who downplayed this, who is still, in my view, downplaying it. Is that a fair statement?
It's fair. And just as you said, I don't want to take any blame for this myself either. So I hear you completely. I agree. I don't mean it in the collective we of, like, let's say both parties or anything like that. I just mean in the sense of we as a country. And however that plays out, you're totally fair to say that. But the truth remains that the U.S. today hasn't done the things those other countries have done. And that's the big challenge, is saying, look, we know every country is going to have to shut it down. And when I say shut it down, I mean shut down all non-essential functions. We know this has to happen. And we might hem and haw on our way there. Italy did that initially, Spain, Germany. At the end of the day, all of them did the same thing. And here's the key. The longer you wait to do it, the longer you have to do it for. And the longer you have to do it for, the more your economy suffers.
Let me ask you this. Let me interrupt you and ask you, and again, I really do not mean to be political here. This is a health issue, but you got the president saying, look, he's worried about the economy. We're all worried about the economy. And he's saying, well, maybe in a few weeks, we'll start reopening the economy, start bringing people back to work. Is that, you're shaking your head. I gather you don't think that makes a lot of sense.
No, I think that's not a smart strategy. I think the right strategy is to say, look, let's just handle the problem the way it has to be handled. Let's shut down for as long as we need to and see the number of new cases fall. At that point, we start even beginning to think about, when and how to reopen things. At the moment, we're at a very critical juncture where, we just heard from the representative from 7th District in Washington, Jayapal, who is speaking very eloquently about the challenges they're facing. Washington, in many ways, is kind of the Wuhan of America. They're the canary in the coal mine, and we're lucky that they're as savvy as they are in terms of the science on this. Very lucky. And we need to learn from what they've done and what they've done right to make sure that gets implemented federally on all levels. In terms of raising the line, Senator Sanders, you yourself have made a big issue of handling unemployment, making sure that we forgive student loans. All of that makes 100% sense. And what I would say is that, as much as possible, creating a pipeline where we can get new frontline healthcare workers to wear those N95s, to use those ventilators. Because, again, having all that equipment without people is not useful, right?
All right, explain to me, let me interrupt you. Let's talk about medical personnel.
Mm-hmm.
Let's talk about, it is stunning to me how we don't have masks. I mean, one might, that kind of seems like a no-brainer that this is not the first epidemic that we have seen. Masks are not all that expensive. How does it happen that we don't have the masks, the gloves, the gowns, the other protective equipment that our frontline doctors and nurses need? It is, I don't know if you notice this, I think in Italy, if I'm not mistaken, some 23 medical personnel have already died. I mean, that's a tragedy unto itself. How do we defend and protect the American people if our medical people are sick or dying? How does that happen that we're so unprepared in that respect?
Well, very easily, what I would say is there's a national stockpile. That national stockpile has a budget. That budget gets gutted when no one's looking. And so what's happened is that essentially in the era where we didn't have COVID-19, where we've had other priorities and there's no political will for things like public health, those budgets get slashed and no one really kind of cares.
So is the function of that budget actually to prepare for a disaster? Is that what it's supposed to be doing?
100%. Absolutely. And then when there is a disaster, everyone says, well, where's the stuff we needed? Well, it was gone because no one was paying attention. The other thing that you said, which was critical, Italy had people that were dying, healthcare workers. When one person goes down, just one, that person was, having lunch, going to dinner with workmates, doing procedures with workmates. All those workmates get quarantined, mind you. Now you've got a number of people that are quarantined. That initial person is sick, they may never come back. And then you've got that third wave of folks that maybe weren't quarantined or sick, but now they're fatigued, they're overstretched, they're overburdened, and they're panicked because nobody has their back. Their hospitals don't have their back, their governments don't have their back in terms of getting the right equipment, but are encouraging them to go in anyway. And so that's a dangerous situation because, God forbid those people decide not to go in. Now you've got essentially all the ventilators and N95s you want, but you don't have people that are able to kind of be there. And so that's the dangerous situation that we want to avoid by getting enough frontline healthcare workers in that space.
All right. My impression is that there are many parts of this country, forgetting the virus, that have for many years been underserved, right? There's not an emergency room. There's not a hospital. There aren't enough doctors. What happens now in the midst of a crisis in those underserved areas?
Yeah, that's exactly right. Before COVID-19 was in anyone's vocabulary, before anyone knew about it, we already had a massive need for more healthcare workers. And this was clear. And now COVID-19 came in and essentially exposed our very, very fragmented and fractured healthcare system and showed everyone how truly broken it is.
Right.
And so that's really where we're at, is we're recognizing that that those areas that are underserved are going to be hardest hit by this, because they already were quite hard hit to begin with.
Good. All right, Dr. Desai, if you could hang around for a bit and maybe take some questions and engage in a discussion, I would appreciate it very much. Our next panelist is Dr. Joya Mukherjee, who is an infectious disease doctor and public health expert. She's an associate professor at Harvard Medical School and chief medical officer at Partners in Health. Dr. Mukherjee, can you talk a little bit about what we can learn from what other countries are doing? What have countries done well? What haven't they done well? What lessons might we learn from them?
Yes, thank you so much, Senator Sanders, for having me on. And I want to just say that, to your point of not being political, all health is political. I have been a public health practitioner and an infectious disease doctor for almost 25 years. And health is about the political choices we make. And when we see that countries have been able to control epidemic disease, it's because they are making political choices. And those political choices are always, if there's a positive outcome, those political choices are about taking care of the sickest, taking care of the most vulnerable, taking care of the society. So I think what we're seeing is that countries that have been able to control this are making choices about how to roll out public health and medical interventions. So one of the things that concerns me, having studied deeply what has happened in Wuhan, China, what has happened in South Korea, Singapore, and Taiwan, is that they did not just flatten the curve. They did two things. Flattening the curve, for anyone who knows a little math, is about having the same area under the curve, which means the same number of people sick, the same death rate among people who are sick, perhaps slightly lower if you're more prepared. But what China did, what South Korea did, was more than flatten the curve. They flattened the curve with social distancing and some of the lockdown and stay-at-home practices. But then they did something that we are not doing at all, which was broke the cycle of transmission. And how did they do that? They did that by massive testing of even asymptomatic people, of any contact who would get tested, and then if positive, supported socially to quarantine or isolate safety. Isolation is the word we use in public health for those who are positive, quarantine for those who may not be positive but may have had a contact. You can't ask people to stay at home if they have to work, if they have no food, if they have children to take care of and need to feed their families. So if we're asking people to quarantine or isolate, we have to provide the adequate social support. But for people to know their status, what we saw in South Korea, without any restriction of civil liberties, without any forced isolation, was massive testing. Testing to the point that for every 100 tests that were done, only 2 were positive. By definition in public health, that's a good screening test. What we're seeing in New York, Massachusetts, where I live, and other places, is 10% positivity rate, 30% positivity rate. That means there is silent transmission of the virus among the asymptomatic. And it's been told to us over and over again by many experts, well, if you're asymptomatic, stay at home, or you're mildly symptomatic, stay at home. Of course, we don't want people with COVID coming to the hospital and infecting others if they're not very sick. But if we had access to testing, remote testing, so people could know their status, and then we could help them safely quarantine or isolate, then we've done more than flatten the curve. Then we've shrunk the curve.
All right, let me ask you this. Let me ask you this, Doctor. If you had your druthers, what would massive testing look like? What would it look like in Massachusetts and Vermont? What would it look like?
Yep. That's what I've been working on for solidly for the last week, both for, by the way, countries like Rwanda and Liberia, where I work, where we're trying to break the chain before it gets out of hand with the handful of cases we have. But in a place like Massachusetts, one could hire a huge cadre of contact tracers who could, we have massive problems now of people getting laid off, furloughed. They could be remotely checking on people, and for every person who's infected, noting all their contacts, calling all their contacts, and sending them to a remote testing site. You've seen these, and they had many in Korea, drive-through testing sites. You get an appointment, you get the test, you'd have to then massively scale up testing, which we're starting to do, but slowly, but we have to invest in it. So
Here's a question.
Yeah.
Do we have the available test kits, and are we able to process the results as quickly as we should be able to?
Sure, because all health is political, Senator Sanders. And if we had the political will, we could do it. And that's what was done in Korea. That's what was done in China. Are they more advanced societies or richer societies than we are? No, they're just making different political choices.
So we could do it. We have the capability.
Sure.
And we have the expertise, obviously, to do it.
Absolutely. We developed many of these kinds of tests. Polymerase chain reaction. There was just a rapid antigen test approved today by the FDA. There are tests in China that, because of tensions between our countries, we are maybe not considering rapidly enough. I don't know the politics there, but we have to make that choice. And lives depend on it. And flattening the curve, in my opinion, as a human rights doctor, is accepting far too many deaths.
I want to get back to this issue of how quickly we can process the tests. And the important point there is if somebody is sick but doesn't have the virus, they don't have to be in the hospital. You want beds for the really sick.
Of course.
How far advanced are we in being able to process these tests in a few hours?
I think there are labs now that are processing them in as little as 2 or 3 hours. But the problem is the backlog. So I have a good friend who was a known contact of a COVID patient, and this is a very common story, and waited 5 days for a test. Living in a household with vulnerable people, that is not an acceptable thing in the richest country in the world. That is a political choice.
All right. What did I not ask you, or did you not discuss that you'd like to?
I guess the one thing I would add as a public health professional is we have made other political choices for many years to dismantle our public health infrastructure. So it's not only epidemic response, it's frontline public health nurses, civil servants, people who do outbreak investigation, who support the vulnerable, who understand where people live. That cadre of workers, departments of public health all over the country have been over time, for the last 30 years defunded. And we don't have a good system of public health. And again, it's very, state by state, instead of having a strong federal system. EIS officers like Dr. Desai are some of the most brilliant people we have. But this program needs to be far more robust to handle the crises that we face. So whether it's state departments of health, local departments of health, or the federal mandate, I just think we have disinvested in so much of our public infrastructure that it puts us tremendously at risk.
And this is part of the overall anti-government movement of the last 30 years.
Yes, and again, I believe these are political decisions.
Right. One last question for you. Should we worry about folks in prisons, in homeless shelters, et cetera? Are they particularly vulnerable?
Absolutely, and I am, strongly in favor of trying to have amnesty programs for people who have had, nonviolent offenses. We have far too many people incarcerated as it is, and certainly, it is unfair to put this burden on them. Healthcare for people, incarcerated people, is a very shameful thing in this country, and I've done a little bit of work in some states in the South in prison-related healthcare issues, and there is no real ability of people to get proper healthcare, and the conditions are awful.
Right.
And I think this is just an inhuman thing. And again, I think we're judged as a society by how the least of us, the most the most marginalized, the incarcerated, and this is the work that I believe needs to be done by all of us.
Well, thank you very much for your comments, and please join us. We're going to get,
Yes.
there's some questions beginning to come in, and let me throw them out here. I'm going to mispronounce names, but we have a question from Humid Golenstana, who writes, quote, "I am a psychologist and witnessing people falling apart. This is serious and we cannot get out of it easily. What are we willing to do for mental health?" A very, very important issue. The stress level in this country now is probably at an all-time high. People are worried about themselves, their families, their jobs, whether they're going to have any income. And we're going to see, I'm sure, a spike in an already epidemic of mental health crises in this country. Panelists, who wants to chime in on mental health?
Well, I can take a shot. I mean, I really believe that part of the rebuilding of our public trust and the way we look at the public provision of care has to include mental health services. And in this epidemic and in this stressful time, could we look at aligning some of these economic incentives with actually improving and expanding access to healthcare? And that means mental health care too. And we're really thinking about how to, tie that in to some of the work we've done with COVID-19. I worked in the Ebola crisis in West Africa, and we did a lot of work with Ebola survivors. And a lot of it was mental health work, because it wasn't only the acute illness, but it was the long-term suffering that had been needed on their families.
Okay. Who else wants to jump in on mental health issues?
Senator, I'll just say that our governor asked for an emergency declaration from the president, and we just got part of that granted, which allows us to expand crisis counseling. We did not get disaster unemployment insurance and other things like that we asked for. We're still waiting, but the crisis counseling allows the state to take action to get more of that counseling. We're going to need more resources, all of those things, state stabilization, but it is front and center because people are already feeling that. Come April 1st, it's going to be a whole world of hurt because there are a lot of people that aren't going to be able to pay bills.
Pramila, are you sensing among your constituents more anxiety than was the case a few months ago?
Enormous. We are fielding calls from constituents. We are trying to get information out, even if it's to say we don't know what exactly is going to be in the package or how we're going to deal with this. But I think that anxiety is real because not only are people dealing with the health anxiety of not knowing, and you heard about asymptomatic transmission, everybody has to assume we've got this thing. But they're also dealing with, how do I take care of my mother? How do I take care of my kids? How do I pay my mortgage?
And your kids are not in school, and your mother may be in a nursing home, which scares the hell out of you also.
Exactly. And you literally have a whole series of bills coming due. Some people may have paid through March, but we're starting to hear a lot because we're coming on the end of March. And, and there's a lot of people who have already lost their jobs.
All right, so what we're talking about is the interconnectedness of everything.
That's right.
Who is Abdul? Do you want to jump in, or who is?
Yeah, no, I certainly agree with Dr. Mukherjee's and Representative Jayapal's points about the structural realities that force people into a moment where this pandemic has literally exploited all of their vulnerabilities. But I want to speak to just some of the practical things that people can do. Social distancing doesn't have to mean social isolation, and I do think that it's easy in this moment where we're staring down the barrel at something we don't know that's causing us a tremendous amount of anxiety, trying to figure out how to make ends meet, to feel very alone. And I think that it's really, really critical that folks reach out to each other and talk to each other about the challenges that they face. We're we're social beings and we crave human contact, and this ain't it, right? And it's great to be able to see your faces, but it's not the same. And so being able to just reach out and have a really honest, open conversation about how you feel, about your frustrations, about your anxieties. And if you're not feeling like you need it, then somebody else does, and you should be reaching out to that person in your social circle as well. And then the last point I'll make is that for those of us who are lucky enough and blessed enough to be quarantining with family, for me, I just know that I always try and find the silver lining in every cloud, and I've spent more days with my little 2-year-old in the last several weeks than I have in a long time, because most of the time I'm on a plane, but that's not happening right now. And so being able to say, look, my life has been turned upside down by this thing, as all of ours have. But I'm lucky enough to be healthy. I'm here with somebody I love, and the rest of my life doesn't usually give me an opportunity to spend time with this person. Let me do that now. Because I have that time. And then I think for a lot of folks, it's forcing us to actually rethink, like, what are the things that are really important? Like, I spent all this time doing all these other things, and now I don't really need them in my life, and like, where should I be centered? And so if that's an opportunity for you, then maybe it is that small silver lining in what is a very dark and very scary cloud. And so reach out to folks, spend time with the folks that are there with you, and try and build connections. Even as we socially distance, it doesn't mean that we should socially isolate.
And I would add to that, while we're sitting home and socially disconnected to others, we might want to think about how we got to where we are, and why, for example, there is so much anxiety, economic anxiety. Why don't we have healthcare as a human right? Think of what that would mean. If everybody, right now, the bill that will probably be passed tomorrow will guarantee coverage for testing. That's great. And yet, what happens if I have the illness and I end up in the hospital? That may cost me thousands of dollars. What happens if I don't have the money? What happens if I'm uninsured? All right. So the other question that we have to ask ourselves is, I worry very much, and there hasn't been enough discussion about this, is half of the people in this country are living paycheck to paycheck. And paychecks are stopping. What's going to happen to those people? What do you do if you don't have a paycheck to feed your family? Now, hopefully the money from the government will get out soon enough. But needless to say, the anxiety level is terribly high. All right, we've got another question. This comes from Kimberly Mims, and she writes, quote, "Is there a reason to worry about a second or third wave of this virus? If so, what could we expect?" Who wants to take a shot at that one?
I can address that. So one of the things that we've talked about with COVID-19 is the fact that it started from a coronavirus, from bats.
More questions.
We talked about the relationship it had to MERS and SARS, which were also coronaviruses. These things are going to keep coming. Humanity is going to keep facing new pandemics, new issues like this that we're going to have to deal with. The existential threat, of course, being climate change itself. And so I think as we recognize what's working and what's not, the invariable truth is that we're a very global society, and we can't simply just isolate ourselves, or even at an individual level, isolate our own problems. One of the things that I think is quite beautiful about these issues is that there are solutions that are kind of emerging that you wouldn't have even thought would have been discussed a few months ago. You just mentioned the fact that universal testing is going to be covered. I can't think of an immediate example of another universal test that's covered for everyone, no questions asked. But clearly people see the value here. And maybe this is the beginning point for kind of expanding that out and scaling that out. There is a proposition you mentioned about, universal basic income. That 6 months ago would have been considered quite progressive and maybe out there. But now we're doing it. Both sides recognize the need. So I think that there are moments like this, and there will continue to be moments, probably more and more of them, where we recognize that these solutions are not so far-fetched, but that actually they're very necessary, and the faster we implement them, the better off we are as a society. On the point of anxiety, I just want to add on the last question about unemployment. One of the beautiful things that I see, one of the silver linings that I think is awesome, is that you see the business community, the education community, starting to step up in ways that they didn't have to. Companies are making ventilators when, 6 months ago they were making cars. They didn't have to do that. And the fact that they're stepping up is impressive. And, one thing that we've had inbound is a number of universities have reached out and said, hey, can we help you, raise the line, as I was saying, can we create a place where people can get employed? So 4 months on, they're not waiting for kind of what's my next paycheck, but they can start getting a career in the healthcare specialties where we know they need to be.
All right, let me jump in and get back to the question. Is there a reason to worry about a second or third wave of this virus? We have heard that in the fall. Who wants to jump in on that one?
Go ahead.
So I just recently interviewed one of the lead infectious disease modelers at Yale for my podcast. It's called America Dissected, where we're actually focusing a lot on these questions. There are a couple scenarios that we are staring down the barrel at. There's one that says that we do this very, very well, and we're all able to self-isolate. We're able to freeze this thing in place, and we see a steady decline in the curve, and it doesn't come back. There's another scenario that says that we find ourselves on that decline, and then we start to loosen the social distancing, and then we see an upswing again. And then there's another scenario that says, well, we know that these infectious diseases are less common in the summer. It's plausible that we see a decline because of the summer months, and then it comes back roaring in the fall and in the winter, which is what happened with the 1918 flu pandemic. We actually don't know. There are competing outcomes from different models that model out all of these different scenarios, and different groups of highly educated experts making a set of very plausible assumptions that predict any of these plausible outcomes. The real point, though, is that the choice that we have in front of us is whether or not we are willing to invest in social distancing right now so that we can maximize the potential for the outcome where there is no second wave, and then we can freeze this thing in its tracks. And so we don't know what the future looks like. We have a number of different models that predict very different outcomes. But the question that we can deal with right now is what we choose to do in this moment to try and get the best possible outcome. And so my frustration sometimes is that we predict, well, this is going to go on for 3 months or 5 months or 18 months. What are we going to do? We're all screwed anyway. Like that's not the attitude. The attitude is we have the potential to reduce the impact of this thing now. We better take that potential. We all better socially distance for right now, do our best. And then if there's a scenario where it comes back, then we'll deal with it then. But right now, we all have a choice about what we're going to do tomorrow, and we all better make the right choice because all of us are in this boat together.
All right. Abdul, you referenced the Spanish flu of 1918. Is my recollection correct that during the summer it receded and came back full-blown in the fall? Why is that? Why? Explain to non-experts why viruses recede in warm and humid weather.
I wish there was a simple answer, and the honest answer is we have a lot of hypotheses, but we actually don't know for sure. One reason is that when the amount of time that a virus will survive in an air droplet or on a surface is just lower when it's warm and humid. The other answer is that human behavior is very different when it's warm and humid, and the amount of time that we spend cooped up in small places is lower. And there are other plausible arguments about why. It's also that every one virus that has its moment in the fall and winter, the cumulative impact of all of those viruses together reduces your body's capacity to fight any of them and all of them. So it's all of those three answers plus others together. But what happened in 1918, at least, is we know that because society's capacity to even know the global experience was limited, right? We couldn't send information across the world as quickly as we did back then. Plus, our ability to keep people alive was substantially lower. And so as people just kept living their life because there was no real concerted public health intervention like we're doing right now, that it started to dissipate. But what did happen is actually the bulk of deaths happened after those summer months because it came back in full force in the fall. There are a lot of reasons to believe that scenario is very different than what we're facing right now, in large part because we're all working on trying to address this thing. But we're not sure. That's the thing. We're not really sure. What we are sure of is that we need to continue to socially distance, that insofar as we can eliminate people communicating this virus to other people, that it will have a real impact on how long this lasts and how many people die, that we should be doing all we can to prevent that.
Okay, we have a question that came in while we're on the subject with transmission here. The question is, how long can the virus be transmitted from touching certain objects or surfaces? Can it be transmitted on clothing, in hair, etc.? Who wants to take a shot at that?
I'll try to answer that. So one way to divide up how things transmit is to think about porous and non-porous surfaces. So a non-porous surface is kind of a hard surface. So let's say a cell phone, a sink surface, a doorknob. Those are non-porous, kind of firm, hard surfaces. Porous surfaces are clothing, pillows, blankets, things like that. So generally speaking, you're looking at two things: not just how long does it survive, but how long does it survive and then transmit. And typically with these studies, they're looking at how long it just survives. And things do survive in the environment for a considerable period of time, but that doesn't necessarily mean they're going to transmit at the end of that duration of time. There's also one more factor, which is that over time, the amount of virus is going to go down. So it's dying over time. And that's called the inoculum. So the inoculum you get is going to be a lot less 3 days out than if you just touched it on day one. So those are a couple of factors that you should think about when you're hearing these studies of 3 days or 17 days was just reported today in the news. These numbers have to be caveated with those kind of thoughts.
Okay, let me throw out what I think will probably be the last question here. It's almost getting back to how we began. This is from Ali Law. What symptoms should someone have to signal that they need to actually seek help from a doctor? In other words, when do you really need to go to a doctor? Who wants to take a shot at that one?
I would just like to encourage, I mean, I think we do have this limited testing, but I don't think we should, as medical professionals, only be looking at the scarcity that our political choices have led us to. So I would say, if you are sick, and with symptoms of a fever, aches and pains, coughing, you should contact a doctor. You shouldn't necessarily go to a facility, but there are many primary care doctors now that are doing telemedicine consults. We are in a changing environment where tests are more rapidly available. Don't wait till you're short of breath. There was a tragic story from Washington of a 30-year-old woman who was found dead in her home with a 4-year-old child. Don't wait, and it's not just the elderly. This virus is felling many young people, so contact someone and see if you can at least get advice on the phone from your physician or a nurse or a telemedicine consult.
All right, on that note, let me thank all of our panelists. You were great, and we appreciate you being with us this evening. Let me thank all of the folks out there who are viewing the program, and we will see you all soon. Everybody stay healthy and listen to what the doctors had to say. Okay. Thank you all. Good night.
So actually, the song "Which Side Are You On" is an old song, but through the years, Pete Seeger did a version of it, and Ani DeFranco's done a version of it, Billy Bragg, a lot of different people. My father did a version of it, and people have changed the verses over the years. So it's been one of those things that's like, it's a folk song, and oftentimes it's what we do in folk singing is we change the verses to make them relevant. So I wanted to update the verses, but the chorus is so powerful, because we have a choice right now. And as much as I'm in it for we're all one, and as much as I'm, all about, talking across party lines and really like making sure that we feel united as a country, there's a choice to be made right now. And that's a really powerful chorus. And I wanted to use that. So we now have a new version for Bernie's campaign. Which side are you on? 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 Come on, all good workers, this year is our time. We've finally found a leader. what's on our minds. Which side are you on? 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 Oh, people, can you stand it? Oh, tell me how you can. We'll either have a Green New Deal or a God-forsaken land. Which side are you on? 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 Will you hoard your billions or share your gifts with mine? Are you with the 1% or with the 99? Which side are you on? 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 Will we build infrastructure or build a bigger wall? Will you vote for corporate cuts or Medicare for all? Which side are you on? 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 Don't fall for their tactics. Don't listen to their lies. Us working folks haven't got a chance unless we organize. Which side are you on? 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 Just one question still remains to which we must respond. Two roads lead from where we are. Which side are you on? Which side are you on? Which side are you on? Which side are you on?